Do I have to press that?
Hello, everybody. This is a take of GYN Oncology Garage. I'm Ed Pavlik in Lexington, Kentucky in the States.
And I'm Frank Lawton from London in Great Britain.
Good to have you with us. We're going to have a look today at a paper that appeared in the British Journal of Cancer called Validation Analysis of the Novel Imaging Prognostic Radiometric Signature in Patients Undergoing Primary Surgery for Advanced High-Grade Serous Ovarian Cancer. This is a retrospective study, and it looks at a predictive model for seeing if survival on advanced stage disease can be advanced, predicted, foretold by this radiology type of approach. Frank, what do you think of this paper?
I think the first thing is that it may be original from the point of view of epithelial ovarian cancers, but obviously using radiomics is something in a lot of other soft tissue, lung, breast cancer, and other soft tissues. Fotopoulou's team at the Hammersmith launched a paper, or presented a paper about a year ago, where they started to look at these algorithms and produce this vector. And what they've done in this paper is to present data from another institution using the same algorithm to try to determine whether or not it's reproducible and offers the prediction that they suggest it does. So they chose a center in Essen, which is well known for its radical pelvic surgery, and the protocols that they used in the Hammersmith were used for a good sized number of patients, about 320, 300 odd patients. Interestingly, the patients were overwhelmingly poor prognosis to start with. More than 90% were FIGO 3 or 4, and obviously by the nature of the disease, they've got G3 tumors. So I think they were trying to find the sort of worst possible prognostic group they could find in order to perhaps show that something might become of these data. So they in the paper, they show how to measure the RPV, and then they produce some data suggesting that if the RPV is high, then this significantly affects the progression-free survival. With a low or medium, it's about 18 or so months, 26 months. With high, it's about 18 months. But of course, if you look at what the algorithm does, it actually is measuring, and they mention it, it's measuring bulk and other tumor characteristics. So I'm not so sure whether it's the RPV per se that has shown that it's the progression-free survival is different, or that it's the fact that they're dealing with bulky disease and a poor prognosis anyway. The other thing they say is that with a low RPV, there is a greater chance of complete macroscopic clearance. Well, that again could just be a function of the stage of the disease or the extent of the disease at surgery. When they do a univariate analysis to look at the outcomes, FIGO stage, the amount of residual disease, the performance status of the patient, and the RPV are significant factors in a univariate analysis, and also in a multivariate analysis. Or the ECOG, the performance status disappears, but in a multivariate analysis, it's the same. So I'm not so sure whether or not it's the FIGO stage and the residual disease that is actually just as important as this RPV. The other thing that's interesting is that they look at survival, and in 1 year survival, there is no difference whether or not you've got a patient has a raised or high or a low RPV. And that's probably, if they're going to be honest, because nothing much happens in the first year after someone's had surgery and is undergoing chemotherapy. So I suspect it may just be that there weren't enough things happening to show any difference. But in the second and third years, there did seem to be a better outcome for patients who had a lower RPV. The paper says that this may be because Avastin, the endothelial growth inhibitor, was being used by the German team. So they're almost implying that, well, it's not the surgery that made the difference, it's the fact that the RPV just predicted or just showed a group of patients who were also being treated with post-operative treatment. So again, I'm not so sure that it's that important. So what they say is, okay, then perhaps what we could say is that this indicates a high level of early relapse. That if you've got a raised RPV, then you've got a high chance of early relapse, which I think is probably true. But on the other hand, if you've got FIGO stage 4 disease and a poorly differentiated tumor and a lot of disease, you've probably got a pretty high chance of relapse. So I'm not so sure whether that stands alone as to whether it could predict what they say it could predict. The other thing, of course, is that is it any better than conventional imaging? Now, I know that with the algorithms, things may be seen that are not apparent to the naked eye or to the observer, but perhaps a more interesting study would be to use this against conventional CT, which clearly is a lot cheaper than what this would be. And also, how reproducible is it? Because clearly there are differences in the data that the Hammersmith generated and the data that the German group demonstrated. So I'm not sure that it's transportable to all the clinical situations that it suggests should be. That's my feeling of it anyway. It's an interesting paper, and I think it's probably people finding something to do, but I'm not so sure that per se it actually sets out to do what it says it does, or doesn't do it any better than conventional imaging and conventional follow.
I agree with you, Frank. There's no doubt in my mind that there's a difficulty in porting this to the everyday caregiver or everyday surgeon. The actual difference in improvement overall is a difference between a prediction of 25% survival versus 10% survival for the high versus low scores. And in the group that really all cancer has been removed, the prediction gets, the predictive capability of the radiography gets much better by about 10%. That's interesting in of itself. If, for instance, a surgeon feels that he got everything and is really speaking the truth as far as he's concerned, then there may be some utility here for saying, okay, can we point out the group that needs to go to sort of the big guns of chemotherapy versus those that they can be spared from that. So that would be just focusing on the we got it all group, the true no visible disease left behind.
Yeah.
So I think that's pretty interesting. And I think that would be a real topic for a prospective trial. This, of course, is retrospective. In that sense, your perspective would be high dose, high powered chemotherapy versus no high dose chemotherapy. Yeah. Picked out by the group that has the high scores versus the low scores.
Yeah. Yeah.
The last thing I'll say is that really overall, the predictive ability of this test has been finding 20 people who survive longer, namely almost 50 months out of 176 people. And so it really raises the question, what do you do with that 156 people if you were doing this prospectively? Do you just say, we've done this look radiographically, it looks like the test says they're not going to benefit, and do you then refrain from doing anything to them? Do you say, just let them go? And that's a hard question.
Absolutely.
A very hard question. And it leads to a more of a horizontal question, looking at the horizon, what I mean by horizontal. What risk factor, what hazard risk factor running from 1 to what would you say is the number we should look for to say, okay, we're going to have one group that we really predict a benefit by doing one thing, and the other, it won't make any difference if we don't do it. And I'm looking at here in this paper a risk factor, a benefit of 1.69. I certainly wouldn't argue with a risk factor of greater than 2, hazard ratio of greater than 2. That would really cut the group in half. You'd have the group that would benefit and the group that wouldn't. But this is the big question, not just for this approach, but for any approach down the road. What type of risk finding do you say will justify, either a very harsh treatment but a big gun treatment versus not doing anything at all.
I think that's a very good point. And of course, the other problem is going to be, how do you explain that to the patient? That we've discovered that, you know, you were in a very poor risk group. We don't want to actually give you anything. I can't imagine too many patients or their relatives are going to say, that's fine, doctor, thank you very much, we'll just go on our way now. And I cannot honestly think there's a lot of radical pelvic surgeons would be prepared to say the same thing, because it's in their DNA that they feel, rightly or wrongly, that maximum debulking overcomes a lot of the poor prognostic factors associated with ovarian cancer. It's never been proven, as we know, and it probably will never be proven. And I think the ethics that you've just brought up of what do we do if we actually know up front that a patient's going to do badly? Do we give up, or do we, or possibly hit them even harder with something else, or a more expensive drug? And I don't know what the answer is there. It'll be interesting to see how this continues, because I suspect there are quite a few people would be interested in trying to reproduce the data, particularly if it finds a group of patients who will do well or a group of patients who will do badly. But then scheduling treatment, nice treatment versus heavy treatment on this, I think is going to be extremely difficult. It won't get into mainstream clinical practice, not for a few years anyway.
Well, thanks, Frank. It's good to see you again.
Yeah.
That takes care of us for Gynonc Garage this time. We hope to be able to do it again.
Excellent.